Hello, everyone, and welcome to another episode of Medicine 3.0 podcast. I'm excited to be with Catherine and Isaac here today, one of our great physicians on our team, talking about our vascular module, so you can get a little bit insight of what to expect and what to look forward to when doing this module. Kat, anything you'd like to say to start us off?
I'm excited to talk with Kelly Joniak, one of our amazing Bionic Advisors here at Bionic Health. And I'm excited that we have such an incredible team that we work with. So let's talk about Vascular Module.
Awesome. Let's dive right in. Can you walk us through a little bit of an overview of what to expect when someone begins this module?
Sure. First, I'll just start off by saying when our members join Bionic, everyone goes through our Bionic baseline evaluation. And during that evaluation, they're going to get an initial set of labs that includes things like a lipid panel, ApoB, lipoprotein A level, cardiac CRP. And these are some of the tests that we look at that help to identify risk factors or risk modifiers that suggest that a person needs to further address their cardiovascular health. So, and in addition to that, we're collecting history. So do you have a family history of a parent who's had a heart attack or a stroke or something like that? So we're collecting a lot of data, and that helps us to identify the members that are going to benefit from our vascular module. We're trying to assess for risk. We also do our blood pressure module, which helps us calculate their 10 or 30-year risk for cardiovascular disease. So by the time that people are entering the vascular module, we've already collected a decent amount of data that helps us to understand where they are in terms of their risk profile. And so when I'm recommending vascular module, I'm recommending a deeper dive with some additional labs to further evaluate risk. So there are some lab tests that are done in this module that are not done at baseline. And that is important because we don't like to do a shotgun approach for our members. We could certainly order every test under the sun on every member that joins Bionic Health, but we do not find that to be useful. We like everything to be done in context. Again, we're not going to just do this shotgun approach. We're only going to do these additional labs when we feel that it's important and relevant. So within the vascular module, I'll just explain which tests we're evaluating. So we do, again, a repeat lipid panel, lipoprotein A, and an Apolipoprotein B. Maybe I should talk a little bit about each of those tests to begin. So your lipid panel, most people get that when they have their traditional visit with their doctor. That includes their total cholesterol, their triglycerides, HDL cholesterol, and LDL cholesterol. Now, we use these numbers, particularly your LDL cholesterol, in conjunction with an Apolipoprotein B to help us to understand what a person's risk is in terms of how likely they are to be building up plaque in the wall of their artery. So Apolipoprotein B is a test many people have not had done before when they have their traditional doctor visit, and it's one that we think is quite important. Apolipoprotein B is part of the LDL cholesterol particle complex, and it's a carrier protein that wraps around LDL cholesterol and carries it around your bloodstream. Because lipid particles are fat soluble, not water soluble, they cannot traverse your bloodstream alone. They need someone to carry them along. So Apolipoprotein B is a reflection of how many LDL cholesterol particles are migrating through your bloodstream. And you can think of it as if you have a high number of ApoB particles, that means you have a high number of LDL cholesterol particles floating through your bloodstream. It's very congested, and there's a greater likelihood that you're going to have these particles bumping up against the endothelium, which is the wall of your artery, and getting embedded in there. We're using this data to help us understand how crowded it is in your blood vessel in terms of LDL cholesterol particles. Lipoprotein A is a genetically predisposing particle that increases your risk by about 6-fold in terms of atherogenesis. So let me say that a little bit differently. Those particles are 6 times more likely to promote plaque buildup. So if a subset of your particles floating in your blood are highly oxidizable, then you're more likely to produce plaque. So we're identifying which members of ours have this additional risk factor for plaque deposition. And then we're also going to be checking some inflammatory markers as well. But I'm going to pause there because I just gave a lot of information and you might have some questions, Kelly.
Absolutely. Well, thank you for going over the baseline module and the blood pressure report. I think that's an important step that adds a lot of value for members, and it sounds like helps parse out who is indicated for the vascular module. I'm sure everyone can have some benefit from it, but what's the priority? What's going to, like you said, give you the most bang for your buck, so to speak? So we're not taking the shotgun approach, but kind of piecing together puzzle pieces and trying to tell a story with the data rather than saying, oh, we can just test everything.
Right.
So that was great for our members to have a little clarity on the thought process to why things are being shared. One question that might come up with some of the blood biomarkers, obviously we're acutely looking at these levels that are occurring in the blood at a certain moment when the blood is drawn. Are these helpful for looking at chronic indications? Because you're not necessarily evaluating calcium buildup unless we're getting like a coronary artery calcium score. So can you provide some clarity on what those values are showing you at those times?
Sure. Your question, I think, is an interesting one because, and I didn't talk about coronary artery calcium scores. I can certainly talk about that, which is not directly attached to any particular module. But the labs, when we're doing the vascular module lab work, it is a snapshot in time, right?
Mm-hmm.
So it reflects, within a week or so of what you've been doing in terms of your dietary intake. We ask all of our members to fast when they get their labs drawn, and that's important for accuracy as well. But in terms of the half-life of each of these particles, particularly your LDL cholesterol particles, they're around for a couple of days at most. So you're going to be picking up more acutely what you've been doing dietarily, which is important. That's for your lipid panel specifically and your ApoB. For your lipoprotein little a level, there is a little bit of fluctuation with diet, but in generally, this is not something that requires trending out per se. It's something that you can test for one time in a person's lifetime to identify if there's someone who's, has a higher particle number versus a lower particle number. However, there's some caveats to that. So, for instance, women pre and postmenopausal can have changes in their lipoprotein little a levels because estrogen does impact lipoprotein little a production. So, if a member, let's say, is 35 and premenopausal and has a lipoprotein little a level that is in the intermediate range, but not necessarily what we consider high threshold, I would consider checking it again when she's either peri or postmenopausal because the number could then rise. And actually, I'm a good case for that. My lipoprotein little a level did increase, I want to say by 20 nanomoles per liter, if I have my units right. So that's an important thing to consider for members, but that's not something that necessarily needs serial checks. Another thing that can impact your lipoprotein little a level is being started on a statin. And we don't use that as a reason not to do statin therapy. We just understand that there is going to be a change in the level when a person is started on a statin. So I know I provided like several answers to your one question just because it touched on a number of things. But yes, so the labs that are done with Vascular Module are really more of an acute snapshot of what's going on, as opposed to using something like coronary artery calcium score, which is a non-contrast CT scan that we often recommend for our members. And I usually will recommend this again at baseline evaluation when I feel like they have either a family history or their LDL cholesterol and ApoB levels are elevated, which put them in our category of being, medium or high risk. And it really helps to elucidate even more clearly what's going on at the level of the artery. So years ago, we didn't have an opportunity to really understand if there was plaque deposited in someone's artery, unless we went in there and did a cardiac catheterization, where you actually insert a catheter into the groin, and you pass it all the way up into the coronary arteries and inject dye, and then are taking real-time images to see how that dye is flowing through the arteries. But for a while now, we've had the opportunity to use imaging with CT scan, which is non-invasive, to get a look at the coronary arteries. And there are two different types of studies that can be done. One is a coronary artery calcium score, which is a more basic, again, non-contrast CT scan. When I say non-contrast, what I mean is you're just going into the machine and they're taking a picture. You're not getting any IV dye injected. That is a coronary CT angiogram, where you'll have an IV inserted into your arm. At the time that they're collecting the images, they're going to be injecting the dye, taking the pictures as the dye is traversing through your arteries and lighting them up. And with that type of study, you get images pre-injection of the dye. So it's like you're doing the coronary artery calcium score, and then they also take images after the dye is injected. And I'll just explain a little bit about each of that again. So why do we care about the coronary artery calcium score? Why am I talking about calcium? Well, we start to develop plaque. We have fatty streaks in our arteries that can be found as early as our teenage years. And so atherosclerosis, which is plaque deposition in the wall of our arteries, is a lifelong process that takes decades to develop. When it's initially laid down, that plaque is soft. But over time, as your body is trying to, remodel that plaque and wall it into the artery so it doesn't flick off and block the vessel, it starts to calcify and harden. And so a coronary artery calcium score is quantifying how much calcified plaque is visible on that image. And you can compare your score. So let's say a person who's a 55-year-old male comes back with a calcium score of 30, you can compare that score percentile wise as to how that compares to other males in that age group. So you can see, compared to someone my age, I have more or less calcified plaque in my arteries. So that can be useful just to give, especially a patient, an idea of like, wow, I have plaque in my arteries and it's more than would be expected for my age group. That's concerning. I definitely want to be aggressive about addressing that. And then the coronary CT angiogram gives you that information, plus the additional information of looking at soft plaque and quantifying narrowing of arteries a little bit with more definition because of the use of the dye. We take that information and, baseline information, and then again, we get a bit more data with some of the additional tests that I'm going to talk about momentarily that we do as part of our vascular module. But again, I'll stop there because I shared a lot of info.
That's very helpful information. I think sometimes there's confusion around the testing and what we're looking for and why. I know that we'll get into some of this a little bit more and that there's more testing to walk through. But at this moment, based on some of the calcium buildup that we've talked about and some of the lipoprotein (a) metrics that we've talked about collecting, what sort of lifestyle changes are most helpful for people? I think there's two boats that we can put them in. So let's say we have the person that might not show any high calcium buildup in the arteries from their coronary artery calcium score, and their lab panels look pretty good, but maybe we have a diet log and maybe the diet could be shifted, for example. And then on the other side, we have someone that has a very, very high coronary artery calcium score. Labs aren't looking optimal at all. What are the paths that you're going to recommend for these people?
Absolutely. So yeah, we can definitely triage depending on a number of things. So we're looking at total risk factors and the data. So let's start with simple first. So let's say at Bionic, we're not interested in having our members just come back with their normal labs and saying, hey, everything looks fine. There's nothing wrong. What we're actually quite focused on is prevention. So I do have a number of young members who come back, let's say a 35-year-old man who has an LDL cholesterol of 110 and an ApoB of 90, let's say. And they don't have any family history of early onset heart disease. They don't have hypertension. they're not obese. For someone like that, I'm going to say, hey, your numbers are not optimal, but there's nothing overtly wrong at the moment. So let's talk about some lifestyle modification. Certainly going to want to make sure that that person is doing regular cardiovascular exercise, making sure that their weight is in a healthy range. And in terms of dietary modification, it's kind of the things that many of us hear about, which is, minimizing processed food, pre-prepared foods, fast foods. So trying to eat more fresh fruits and vegetables. And we're big proponents of the 800-gram diet at Bionic, which, as you know, Kelly, is encouraging folks to get 800 grams total in weight of fruits and vegetables throughout a course of a day. And 800 grams is about 6 cups in terms of volume, if many of us are not necessarily weighing our food. So we're just trying to increase the proportion of healthy foods in a person's daily intake, and then reduce the less than healthy foods. Along with that being, minimizing saturated fats in the diet. So that's like whole milk, dairy products, eating red meat that's not lean. And I know you always encourage our members to make sure to get like 93% lean or more when they're picking out their sources of protein throughout the day. So that would be something, that we would be tailoring for our member who's lower risk, but maybe doesn't have the most optimal LDL at ApoB panel. Now, if we have people who are have any evidence of coronary artery calcium, or have, let's say they have an elevated lipoprotein A, which is 125 nanomoles per deciliter. Actually, I think I have my units, or greater, and their LDL is, 110 or 120, or they have an elevated cardiac CRP of 3, then we're going to want to be more aggressive. A person with an extremely strict diet can reduce their LDL cholesterol by approximately 20 to 25%. But that's oftentimes not going to get them into the target of what we consider to be optimal. Again, with somebody who has known risk factors like the elevated lipoprotein A or known coronary plaque, to me, that's kind of like just a suboptimal approach. Like, you could certainly do dietary modification and bring your numbers down. But from my perspective, if it's my heart and there's plaque already there, yeah, I'm going to do the lifestyle change. But I also want the medication that's going to significantly drop my numbers down. And you can dramatically drop people's LDL cholesterol and ApoB with statin, for instance. Depending on the intensity and the dosage of the statin, 30 to 40%. So, and sometimes I've seen more than that. Again, it depends on what someone's story is in terms of the approach. And as I'm talking about that, I'd love to talk about an element of the vascular module, because it comes into decision making. So I'm going to transition to that.
Perfect. That's excellent.
One of the tests that we do in the vascular module is something called the cholesterol balance test. And we're looking at intermediate molecules in the cholesterol production and synthesis process. So basically, it allows us to determine if someone is predominantly producing and synthesizing cholesterol in their body, or if they're reabsorbing sources of cholesterol from their intestinal lining. And so we can determine if someone's a higher absorber, a higher producer, and that also helps us to be more personalized in our approach. So, for example, let's say I have someone who doesn't have the target LDL that I'm looking for and their target ApoB, and we do a cholesterol balance test as part of the vascular module, and it says that they're a high absorber of cholesterol. For that person, I might actually be able to achieve our target for them with a medication like ezetimibe, which blocks intestinal absorption of cholesterol. So because I know that specifically about them using the cholesterol balance test, it helps me to provide a more personalized method of approach for them. And One of the big components of my job is dispelling myths around statins. A lot of people reflexively balk at the idea of having to take a medication on a daily basis, particularly ones that they hear about in the media are bad for them. Oftentimes I'll ask people like, well, what have you heard? Many times people can't say, will say, I don't know. I've just heard bad things. Some people are aware of the fact that statins have the potential, I think it's at about 10 to 15% of people, to cause muscle aches. So that is concerning to them, understandably, of course. But again, so using something like the cholesterol balance test helps me do a personalized approach. And I could say then also, if it's the opposite scenario, look, you're not really absorbing much cholesterol from your intestine. You're really more of a high producer. So this data tells us that the statin is going to be effective at reducing your numbers. And so it's not something that's required, but it certainly gives us the ability to have a nuanced approach.
Thank you for bringing that up. I think that is something that we hear a lot about with our members, and I'm glad that we can dispel some of those myths, knowing that there's a potential for side effects with any medication, but it really sounds like the rewards outweigh the risks of that specifically, especially when we're dealing with potential calcium buildup in the vascular system, and that has way more negative effect throughout the body, longevity, and just overall quality of life as well. So thank you for addressing that.
Yeah,
I
absolutely.
know that you had referred to some of the some of the inflammatory markers that you test for. Can you walk us through that portion of the module, and the other missing pieces that we want to synthesize with what we've talked about already?
Sure, yeah. So some of the additional inflammatory markers that we look at are high sensitivity CRP, which is the same as cardiac CRP. It's an inflammatory marker. It's a non-specific inflammatory marker, however. So even if you have an elevated high sensitivity CRP, it doesn't necessarily say that it's elevated because of what's happening at the level of the artery. There are other things that can cause inflammation in the body, which would cause an elevated CRP. So again, everything's taken into context. And I liked, as you said earlier, that everything is part of a story that we are building for each of our members. And the same thing about the other inflammatory markers that we're using, looking at IL-6, and we also check homocysteine levels. Because these things have been associated with increased risk for cardiovascular disease, but all of them being non-specific. So part of just kind of telling a story and helping to understand what's going on. Another additional test that we check are, which I find useful, especially in terms of dietary recommendations. We check something called the fatty acid balance tests, which give us an idea of how much saturated fat is found in the body, and we can check an omega-3 index. And the omega-3 index is a test that looks at the makeup of the red blood cell lining, and it compares unsaturated fat content versus saturated fat content. And so an ideal omega-3 index would be greater than 8. Most of the time, especially folks that are eating an American diet, they have a very low omega-3 index because they're not really getting significant source of fish in their diet. And the fish is the source of the EPA and DHA types of omega-3 unsaturated fat, which is measured in the omega-3 index. So getting that data is super insightful for us, and it helps us to also tailor supplement recommendations, because that is something that we do. I don't like to ever recommend medications or supplements in excess. I'm kind of conservative from that perspective. I want to only use things that I think it's going to be useful for that person. And when someone has a low omega-3 index, that's associated with increased cardiovascular disease risk. So by measuring the omega-3 index, and if we see that it's low, we recommend supplementation. And then we can also repeat that to see how the body has responded, and then again adjust the dosage if need be. So that's also something that I find valuable for our members. And allows us to, again, provide kind of personalized bend to our recommendations.
That's excellent. I also wanted to emphasize again, I think in general, Bionic, we would say we take a food first approach, lifestyle change approach first. Even if we're recommending medications and supplements, our main mission is to try and help stack all these habits that are helping to create a better environment for your body to thrive and work optimally, right?
Yes.
And I think something I wanted to also mention is obviously we're talking about the vascular module here and how omega-3s and things like that are required and beneficial and often lacking in an American diet. But those don't just affect the vascular system. It's impacting brain function as well, and other things throughout the body, like immune system. So a lot of times we're picking just one thing here or there, but it's having a global effect. It's not targeting one thing. And then with the lifestyle changes, I think we often hear people focused on nutrition as like a calories in, calories out approach, not understanding that quantity and quality are also impacting not just the body function, but some of these vascular items as well. So a lot of times we'll hear like, well, I'm within my calorie range, so I can eat whatever I want as long as it fits, right? But as you mentioned, being really aware of like fiber content and saturated fat is going to be really, really impactful on things, especially in the vascular system.
Yeah, definitely. And I love that you actually bring our attention to that. That's super important because, yes, it's easy for me as a clinician to be able to turn to things like medication and prescriptions. And I also have a lot of members who are quite focused on what are the benefits of the supplements. But one of the things that I like to think about is how much are we moving the needle? And so, I'd rather our members put their effort into things that are going to move the needle a lot, as opposed to things that are going to move the needle a little. And again, kind of thinking back to the 800-gram diet, where eating more fruits and vegetables is associated with lower blood pressure, lower cardiovascular risk, lower risk of diabetes, lower risk of cancers, lower risk of all-cause mortality. And when you think about the side effects of increasing your fruit and vegetable intake, those are minimal and certainly not serious risks that are associated with eating more healthfully. You're kind of getting these additional benefits that are related to that. So that's a habit that has to be consistent. That's not something that you can do once and then expect to have a lifelong benefit. But if you're consistently achieving that habit or that goal, it's going to move the needle a lot. Similarly, with like a medication like a statin, I would say that is low effort involved in terms of just remembering to take a medication on a daily basis, but it's going to move the needle a lot. And so, therefore, I think it's an important thing to keep in our armamentarium when we're trying to maximize a person's health status and longevity. There are certain, I would say, like supplements that are going to move the needle a small amount. So if a person is already maximized from eating healthfully, strengthening their body, and utilizing any medication when necessary, then yeah, you can kind of top off your Sunday with some additional supplements to kind of edge out or squeeze out the maximum amount that benefit you're going to get from that. But that shouldn't be a cornerstone. The cornerstone really should come from lifestyle, as you say.
Amazing. Thank you so much for walking us through the module. Do you have any final thoughts or pieces of the module we may have missed that you wanted to address?
No, I think just cardiovascular health and vascular health is I would say like the cornerstone of important things that we focus on at Bionic Health. And I think coming from the field of traditional medicine, we really were playing catch up more of the time than being proactive. And I would love for everybody in the country to have more of a proactive approach rather than just the bionic members that we see. But I do get a lot of gratification out of taking care of our members, identifying disease earlier than we would have normally identified it had we been using the traditional approach. So I think I just want to share that as a physician, that gives me a lot of gratification to know that we're helping people address things a lot earlier than normally would have.
Thank you for sharing that and for all that you shared about this module. It was so great to talk with you today about this, and I look forward to our next podcast for our members.
Yeah, awesome. Thank you, Kelly.
Thank you for listening to another episode of Medicine 3.0. We make this podcast so that you know where to turn for good information on keeping you and your loved ones healthy. Feel free to check us out at bionichealth.com, where we can help you live a longer, happier life.